I'm Becca. I'm the nurse practitioner in colorectal. Today I just want to talk to you a little bit about transitioning into new bowel habits after you've had rectal cancer surgery. You've had what's called a low anterior resection, which means that you were able to be reconnected, but the doctors, the surgeons removed almost your whole rectum. Most of the time when people have the surgery, they actually end up losing their entire rectum. So once you get reversed from your ileostomy and you're done with your treatment, there's this kind of period of adjustment that can be really challenging and really frustrating. And so I want to talk to you about that today. So basically I want you to understand kind of what's going on with your anatomy, all right? So you've seen this picture, your surgeons have shown you this. This is what the normal colon looks like, right? So this is the right side of the colon going up and then across and then down and around. So you've got your ascending, your transverse, your descending, your sigmoid colon, which is this little turn, and then you've got your rectum. Now your rectum is a very specialized organ actually. And so the way the stool is formed is that it kind of comes loosely into the ascending colon here and then slowly starts to kind of get formed, you know, as it moves through. And as it moves through, it kind of gets into these small little pieces and then they drop into the rectum, and it's actually in the rectum where that kind of traditional piece of stool is actually formed. Kind of the small pieces just land on top of each other, and then they become that you know, typical stool that you're used to, that kind of long snake of stool. Now that is formed in the rectum. Now the colon itself, it's really kind of a simple organ. All it does is really it feels that there's stool there, and it says move it forward. Its nerve innervation is very simple. It says just like stool there, move it forward, move it forward, move it forward. So it basically absorbs water, forms the stool, and then moves it towards the rectum. Now the rectum is much more advanced. The rectum basically can expand, and it's kind of this reservoir, like a vault that can expand and hold quite a bit of stool. And the rectum is the reason that we have one bowel movement usually a day, or one or two bowel movements a day. It's because everybody walks around with stool in their rectum. We're just not aware of it. The nerve innervation is kind of complicated, it's complex in the rectum. So for example, you feel like you have to go, but there's no bathroom. You can kind of shut down the urge to go. You feel like you have to go, but you know, you've got something else to do, and your body can really just kind of turn off that need to go to the bathroom, and the rectum then just keeps piling up stool until you're ready to go to the bathroom. So it's actually a pretty complicated organ, not complicated, but just kind of sophisticated organ, and you have now lost that. Okay, so that means a major change in your bowel habits. So basically what you have now is just the colon attached to the anus. Now you may have a little bit of rectum left, you know, and depending on how much rectum you have left, that can impact your function. If you have a lot of rectum left, it can impact your function. So just again, the colon's job is just to form stool and then just move it forward, move it forward, move it forward, okay? So now that you've lost this, things are gonna be very different. So basically now you've got the stool comes in from the small bowel, it starts to get formed up, and then it just kind of like, you know, almost like just lines up, ready to just come out of the, you know, of the anus. And so the stool is not quite as large, so you're going more often to get the same amount out. And then the nerve innervation here is very simple. So this colon down here is not used to doing the job of the rectum, and it basically will just, you'll feel the urge to go, and it'll just say move it forward, move it forward, move it forward. So traditionally, people in the beginning have a lot of issues with this new setup. And what happens is that people have what we call clustering. So they'll basically feel they need to go to the bathroom, they go to the bathroom, they sit down, they go to the bathroom, they stand up, and they have to go again. So they sit down, they stand up, they sit down, they stand up, they sit down, they stand up, because these small little pieces are coming out. And also the nerve innervation here of the colon is just, it's like, come on, just get this going. Let's get this going. Let's move this forward. So the first 3 months can be really challenging. And the first 3 months are honestly all about anatomy. So let's talk about what the timeline is here. Okay, so 0 to 3 months is the most challenging time. People can have up to 30 bowel movements a day. People can just be stuck in the house where they can't get out, and they're just going, and that is because the anatomy is adjusting. Now what happens over time is this new area kind of becomes aware that it needs to do a different job, and that part of the colon will actually not so much expand, but it'll loosen up. It'll be able to like hold more stool. The old nerve innervation that's still there, I mean, it's never going to be as complex as what you were born with, but of course some of those nerves are still there. They start to kind of integrate and take over and be able to manage things, right? So basically from 0 to 3 months, if you don't do anything, you're going to be really miserable. And so we treat this very, very simply. One is by forming the stool up by taking a fiber supplement. So, this makes sense, right? If we can make the stool larger, you're not going to go quite as often. So fiber will help form that stool up into a larger chunk so that what comes out is more efficient, more effective. The other thing we do is we take Imodium or Lomotil, either one of those, and that will help reduce this urge to go. So this urge to, push it forward, push it forward, push it forward, the Imodium will slow that down, okay? So the first 3 months, I want you to know, is all about anatomy. We're just treating your symptoms with benefiber and Imodium. If you do this well, you can look at about anywhere from 5 to 10 bowel movements a day, so you'll at least be able to get out of the house. The other thing I want you to know during this time is do not think about diet, because I've seen a lot of people actually drive themselves completely insane trying to figure out what the diet trigger is. It has nothing to do with what you're eating. I've had one patient who actually ate the exact same thing every single day and had wildly, varying bowel movements. So it has absolutely nothing to do with what you eat. Now, there may be a really clear trigger. For example, some people are like, I can't drink coffee anymore, or I can't drink alcohol. So fine, you'll avoid those. But in general, it's not about your diet at all. It's really just about making the stool thicker and more effectively packaged with benefiber and slowing down the nerve impulse with Imodium or Lomotil, okay? So make sure you talk to our nurse about this because she can help walk you through the plan. Now, the next 3 to 6 months, if you're still really struggling, then we may look at diet. In general, by 3 to 6 months, you're somewhere between 4 and 6 bowel movements, maybe a little bit better, maybe 3 to 5, whatever. But you're kind of like getting into a regular routine that you can predict and you can kind of go on with your life. But if you're still struggling, then we may look at diet. Now, I almost never do this. It's very rare that we actually have to do this, but when it works very well. So was a gentleman who he was having 15 bowel movements a day. And he did a food diary and figured out that he had been eating a lot of peanuts, stopped eating peanuts, and he went down to 5 bowel movements a day and was able to live his life. Another woman, it was mushrooms, red peppers, there's all sorts of, there's no one trigger, so it's not like that we have a food list. You really just have to figure it out based on your diet. Very few people need to do this, but if you are still struggling, at around 3 to 6 months, then we'll do a diet journal, okay, a food diary, and we'll try to figure out what's going on. And then 6+ months, you're going to be somewhere around 3 bowel movements a day, and then things really just improve over the year. So hopefully will settle down somewhere between 3 to 5 predictable bowel movements where you know when you're going to have them. It may be at night, it may be during the morning, but it's predictable so that you can live your life. Really, people report improvement at a year. So it is a process, and it can be very frustrating. So make sure you reach out to us, because a lot of times when you talk to other people about this, they're not aware of what's called the low anterior resection syndrome. So if you're Googling anything, Google low anterior resection syndrome. That's where you're going to get the information that you need. The other thing to keep in mind is you want to make sure that your doctors, as you move forward in your life, understand that you don't have a rectum, because that really does change your bowel habits very significantly. And so you want to make sure that your doctors are aware that you don't have a rectum, that you seem like you do because you're reconnected, you go to the bathroom normally, but you have lost that because of your cancer diagnosis. So that's it. Good luck, and give us a call, okay? Thank you.